you all understand the importance of the inner layer inside the joints, which is articular hyaline cartilage, which plays a very important role in the load distribution in the joint and in musculoskeletal health in general. And you, of course, understand that whenever this is compromised, either by osteoarthritis or focal cartilage lesions, like the one that you can see in the picture, something is not going okay. And we are facing several problems down the line because we have several characteristics of the cartilage which are quite important for everybody to understand, because these are playing a major role in the decision making and the treatment plan that we're going to organize. The very interesting thing is that it comes from the basic science part of how the cartilage is structured. And this the most important thing is that to understand, to know, coming back to our basic science knowledge from the medical school, for most of us, is that cartilage is really generated by chondrocytes. Chondrocytes, on the other hand, are very high level, differentiated, let's say, perfect cells in the musculoskeletal in the human species. So they do not have that good ability to differentiate and to proliferate in order to help in terms of healing after an injury. But what is fascinating in terms of anatomy, local anatomy in the histological part, is that cartilage is connected, as you can see, here is a subchondral bone. Cartilage is connected through a zone which is called the calcified zone, which is a dense mixed zone between bone and cartilage with the subchondral bone. And then these chondrocytes, who are producing down the line the extracellular matrix, they are producing literally collagen, mostly collagen 2, but also some collagen 10, which is the connective collagen between the collagen fibers. And it is also producing proteoglycans, which are the major factor that attracts and encapsulates water inside the cartilage. That's the most important factor that we need to understand, because water is what is literally is the substance that plays the role in the mechanical loading and the effect and the mechanical characteristics that cartilage has. I need to point out in this now that you can see in these 3 layers of cartilage, the superficial zone, middle zone, and deep zone, how different is the orientation of collagen and cartilage, which are stuck, let's say, in pillars. And then in the middle zone, it is more or less a mesh-like situation, while in the superficial zone, both chondrocytes and collagen fibers are taking a parallel orientation. And you can see this maybe even more schematically in this part of the slide. And this plays the major role, of course, in how the cartilage reacts both in shearing forces, plays a role of a bush who's moving around, like when the wind is blowing. So cartilage can transmit shear forces to a certain level, of course, but also plays a role in the axial loading, playing the role of the springs that absorb energy and then gets back. And this all happens through this orientation that I described and the water that is included inside. What is also very important to understand and to remember from our basic science knowledge is that cartilage, unfortunately, does not have any neural adaptions, and, which is very important, no blood supply. So cartilage nutrients are coming from the synovial fluid through this diffusion between the layers. And there is a barrier in the calcified zone, as we described previously. And you see all the vessels coming to the bone, but not penetrating into the cartilage. So this means that whenever we have a problem, an injury, or a pathology, we have 2 major disadvantages, not 3. Not only the cartilage, the chondrocytes are highly differentiated, so they do not have the best possibility to heal themselves. The second is that we don't have blood supply and neural adaptations in the area, so we don't experience pain, especially in the initial phases where the cartilage defect is not going down to the bone. And this has the third part. This has gives us the disadvantage of not having very good healing response, as you can understand. The final healing response that the cartilage has after an injury, especially when the bone is not implicated in the injury, is to produce a lower quality tissue, which is called fibrocartilage, which is full of, it has higher percentage, of course, of collagen, and especially collagen 2. But the difference is that the orientation and distribution of fibrocartilage, of collagen inside the fibrocartilage, is not exactly the same as the normal one in this part of the slide, compared to this one, which is let's say the fibrocartilage, and this tissue cannot withstand for long-standing periods the loads that the normal hyaline cartilage can stand. Typically, when we deal with a patient who has we are suspecting that he has a cartilage defect in his knee, mostly in his knee, but in other joints as well. Typically, these patients are coming with pain, swelling, or locking or catching, or combinations of these things. Most probably, and I think in our experience and your experience as well, you can see even only maybe a silent swelling without having any extra pain or something like a severe other problem. And in my opinion, take it as a personal hint, let's say, whenever you have a pseudo instability, the patient complains that he has in a certain angle of range of motion, that feels that the knee is unstable, then this gets into a high suspicion into having a cartilage defect. And that's also the situation, the clinical sign that we need to address during our evaluation with functional movement that can reproduce the same situation. But we have to bear into mind that with very high level studies that are published, that almost 14% of patients, athletes at this level, they are asymptomatic without having any symptoms. And half of them, up to 60% of them, they can even have focal, deep cartilage defects, being asymptomatic for a long period, even for the whole season. During this coronavirus crisis, we are not dealing with sports ourselves. So being a sedentary person, myself, in this period, published studies, you can see that knee cartilage lesions during arthroscopy, for any reason, is up to 16%. And for younger, am I okay? Do you hear me?
Yes, we can hear you. We have some background noise, so please make sure everybody, your cameras your microphones are muted. We can hear you. You can continue.
Thank you. And but in sports, the problem is quite bigger, and you can see also some results from published already in 2010 with almost around 1,000 arthroscopic procedures run by in this systematic review. You can see that 1 out of 3 they have symptomatic knees. They do have knee cartilage lesions in arthroscopic evaluation, and 14% were already asymptomatic, as I stated before, and up to 60%, 50 to 60%, they, especially basketball players and runners in this study, they were already having, being asymptomatic, I would say, having a grade 4 lesions. So epidemiologically, several researchers looked into different sports, and we all now know for a fact that we do have asymptomatic patients. We do not know what exactly will happen down the line in their career. And for example, in amateur hockey, 47% of cartilage defects were diagnosed after MRI in asymptomatic, I would say, and stress out again, people. And in this publication from Bezuglov in 2019, last year in Football, they just presented MRIs from pre-season examination in the Russian league, and in 19 knees, they realized that the prevalence of cartilage defects were up to 98%, and 13% of them being grade 4, which is a very high number. And it's also interesting to see that in basketball, in a level of NCAA, for example, you can see difference during the season. And they did MRIs, they had MRIs in the beginning of the season and at the end of the season, and they realized that there is a 10% increase of prevalence in these basketball players. But what we also know from the literature in terms of epidemiology, we do know that in NFL, for example, in a very big database that they have over there, they do something like 8 knee cartilage reconstruction and repair techniques, surgeries per year. In order to speak the same language, we definitely need to understand that we need to have a certain worldwide accepted classification method. And this one, nowadays, in the last, let's say, 10 to 12, 15 years, it's the Icrs classification system, which grades the cartilage defects in 4 different grades, taking into account that the normal cartilage is a grade 0, and it is connected also with a previously widely used examination, which is an arthroscopic examination and a classification from outer bridge. The difference is that in Icrs classification, we take into account the depth, only the depth of the defect, and we're not dealing in the classification in terms of the diameter of the lesion, as this was the case in outer bridge classification. All symptomatic cases in general population and in athletes are literally grade 3 and grade 4. Grade 3 is more than half of the depth of the cartilage, which is already problematic, coming down to the calcified zone. And when it penetrates and goes into the subchondral bone, then we're talking about grade 4 or osteochondritis dissecans. Another important factor in terms of classification, and in order to discuss better, especially in the face of planning and executing rehabilitation, is where exactly is this lesion? Because it's you can understand that it's totally different to have a lesion in the lateral femoral condyle, but when it is covered with meniscus, or in the center of this, or on the other hand, to be in the center of the trochlea. We also know, digging into published data, that we are facing with a problem of post-traumatic and post-surgical osteoarthritis, especially in athletes, even in non-injured individuals. And we know that some risk factors leading to poor outcome are out there, and you can see this in the list, but I will need to stress out a little bit more the 3 last part in the slide. These are already established by good data and good research, that lesions that they are left untreated, lesions that they are not treated properly time-wise. I mean, and when early we deal, we're dealing with 1 year after the first clinical diagnosis and first clinical symptoms, and lesions that they were initially treated with bone marrow stimulation techniques. This last part has a 3-fold possibility to fail later on if needs to be revised with another technique in order to solve the problem. So we need to look for proper treatment in the right time, and not to deal with techniques that we are familiar with, but with the proper techniques. another problem that we're facing, especially in general population, but especially in athletes as well, is that you can find some similarities between people, but nothing is exactly the same. You can see one football player, which I know personally, Jalma Campos. He's not definitely, he looks like, in my eyes at least, looks like Wesley Snipes, but he's not definitely the same people. And the problem we are facing as sports physicians is that in our practice in general, not necessarily in the cartilage area, we are dealing with, we know there is evidence. We know that, and we try to get our best clinical judgment based on this evidence-based situation and medicine. But it's really hard to implement evidence-based medicine in this level of high-level athletes, in professional sportsmen, and in some cases in even lower level, because as I will explain later on, there is not only there are differences, but there are some parameters that make the athletes different from the other people, and these are, in my opinion, and mostly that there is some confusion around, especially in the cartilage area, and not only in the sports, let's say, part of the world, but also in the general population. We have some individual points to address, and in some cases, symptoms and patients do not match with the treatment algorithm that we set up. But the most important factor that plays a role in what we do up until now, and that's why my feeling is that we are underdiagnosing and undertreating these kind of injuries, is that we have to overcome several myths. A myth, for example, is that a myth. I consider this a myth because whenever you face an athlete with a cartilage defect, he thinks that, and his surroundings as well, his environment also think that it's the end of their career. But I will show you some data that it's not the end of the world for them. In order to address what is the proper method, typically for general population, we take into account these parameters: size, location, bone involvement, and other lesions and symptoms. But in the case of athletes, we also need to address these parameters as well, which is age, contract, if there's a contract or not, time inside the season. When the diagnosis was made, it was Christmas, it was at the end of the season, it was in the beginning of the season, a pre-season, and the player role in the team, which also plays a role. You understand that a substitute, a high prima donna player, a very important player for the team, needs to play until the end of the season at least. And we need to do several things. Not only we need to do, but they want us to do several things in order for him to play. And we might postpone what we think that is, according to our best judgment, the proper solution for this case. Another issue, of course, regarding the judgment and our clinical judgment is the size of the lesion, and where exactly is this lesion located. You can see that these 2 square centimeters, let's say, cartilage defect in the medial femoral condyle, in this patient, which is quite big, is less than 1/3 of the diameter of the femoral condyle. But this one, which is exactly the same, 2 centimeters, it's not the same for this patient. It gets something like 50% of the medial femoral condyle, so it's quite different situation, and that's something that we need to address as well. Together with the topography, you can understand that a medial part of the trochlear cartilage lesion is totally different compared to a lateral part, where the patella is getting a lot of stress and loading in the lateral part, especially in valgus knees, and it's a total different thing to deal with a cartilage defect in the anterior part of the femoral condyle compared to this one or this one, which are in the weight-bearing areas, and this plays a role in running, in changing directions, in everything. So in this one, we might do nothing, or maybe a small debridement. In this one, we might need to do something more than that. All the problems regarding our approach in treatment are derived from the characteristics that I initially described to you regarding the the characteristics of the chondrocyte, and we are always in a continuous seeking of superheroes, super cells that can produce extracellular matrix in order to produce normal hyaline cartilage in the area of the cartilage defect instead of fibrocartilage. What really changed the scenario, and it was definitely a paradigm shift, was this publication in New England Journal of Medicine in 1994 from a group in Göteborg. Professor Lars Peterson, who's considered to be the godfather of autologous chondrocyte transplantation, and Mats Bridberg. You most probably know Mats Bridberg very well. So they found through their research started back in the 80s that although chondrocytes cannot proliferate in vivo, they can do this in vitro. So they had the idea of getting some cartilage initially from initially from animals, and then from human, and then try to enzymatically digest it and get the chondrocytes and multiply cultured in the laboratory. And this came into this golden standard technique, which is a two-stage technique that I will describe briefly later on, with autologous chondrocyte transplantation, where you take cartilage from the patient in a laboratory setting, and after 4 to 6 weeks, after being multiplied, and you come back to the surgical theater and implanted in the patient. Another point of research is, of course, together with this very important fact that I described previously with the group from Göteborg, is to how to deal with the concept of stem cells. We thought, and we know from basic science, that stem cells can differentiate into a certain environment, either to osteoblasts or adipocytes or chondrocytes, and we are planning, and the idea was to get some stem cells in the area of the defect, either local or deliver them in a way in order to produce chondrocytes, and the chondrocytes, they can produce cartilage, which is not completely true. The guy who literally gave the name to the mesenchymal stem cells, Arno Kaplan, almost 8 to 10 years now, changed a little bit his attitude in terms of the results of his research, say that the stem cells that we are dealing with all these techniques that I'm going to describe, is they play mostly a paracrine role. That's why they managed to get a new name for these cells, which are now called mesenchymal signaling cells. So the effect on the lesion is that they do give signals to the chondrocytes to come in the area, chondrocytes from the adjacent cartilage, healthy cartilage, to come into the area and try to heal the defect, which is something that is proven that although they do not have this good ability that we described initially, this is something that is quite feasible. And that's these two things regarding chondrocytes and stem cells are the ones that made us group, let's say, the surgical techniques that we use in 3 major groups: the debridement group, the osteochondral transfer group, and the cell therapies, with or without the use of scaffolds in order to keep as many cells as possible in the area. And these cell therapies can be further divided into 2 more, let's say, groups. The ones that they are dealing with stem cells alone, either local from bone marrow stimulation techniques like microfracture, for example, and or delivered in the area, and the donor side would be either fat or bone marrow from other sources, for example, iliac crest. And the second group inside the cell therapies, which is considered to be the golden standard, is the cultured autologous chondrocyte implantation with chondrocytes themselves. And we are moving now more and more into minced cartilage, so having cartilage on the spot in one stage, and isolated chondrocytes with stem cells, signaling cells, in newer techniques. So let me briefly give you some idea of what is going on in terms of surgical tips and tricks, maybe, but you all understand and you know that debridement might be a good solution in some cases because it's very fast, low cost, no morbidity at all. The rehabilitation is quite faster and the return to play is quite faster. And in my opinion, the major advantage is does not burn any bridge, so you can use it as a tool inside the season, during the season, and then you can come up with a final treatment. Although in some cases it is reported that even with a simple debridement, several cases are going fine down the line after 2, 3, 4, 5 years without the need of further intervention. We are about to publish this systematic review that we made with our team is already submitted and most probably will be published in the next couple of months. So we found that the literature is not very big, so there is a gap, but the existing data says that whenever you perform in symptomatic patients, a partial thickness debridement in partial thickness injuries, or in small, medium, and small size in low demand individuals, and coming to athletes, whenever you do this during the season, or even in the late part of their career, athletes with medium and small lesions, I think it proves to be a good solution for these cases. The most widely used technique worldwide is the bone marrow stimulation technique. The goal for this and the aim is to get some cells and some blood to create this super clot in the area, which gradually will develop into fibrocartilage. In small lesions, this is excellent, and with the adjustment of scaffolds that we use in the last almost 10 years, and in the technique that is called AMIC, Autologous Matrix-Induced Chondrogenesis, which is literally a bone marrow stimulation technique, but we keep the cells in the area with the scaffolds, and the idea is to penetrate the subchondral bone to reach this area of blood supply, and then some stem cells will come to the surface, create this super clot, and this will develop into fibrocartilage, which will cover the area. And as you can see here, these are typical nanofractures in this case, and you can see the blood coming, and then creates a small clot in there. Typically, this clot is getting diffuse, but when you use membranes like this, scaffolds like this one is hyaluron-based, you can keep as many as possible in the area, so you can expect better results down the line, and you can stabilize the area with the use of fibrin glue, which is more or less the case for every technique that we're using now. There are a lot, of course, publications supporting microfractures and AMIC, and it seems that although they do have good results in the mid and short term, it seems that the results are deteriorating for larger lesions down the line after 3 to 5 years. But I would stress out the importance of being small lesions. These are very good techniques for small lesions. And in terms of AMIC, it looks like the adjustment of getting a scaffold in the area looks like it gets better clinical scores for the patients down the line, and compared, of course, with simple bone marrow stimulation techniques like simple microfracturing, the results from 2 to 5 years, they look stable compared to the microfractures alone. Another issue is, of course, we are facing several problems with microfractures, especially in the medium and large lesions, mostly because of the intralesional osteophytes that they are developed because of this penetration of the bone, of the local tissue, the local bone. That's why a lot of research is coming for other sources of signaling cells, MSCs, in this case, either from fat or from bone marrow, for example, from the iliac crest, and it looks like a very good solution. So far, what is published says that it seems like a safe solution without having any problems, and maybe overcoming the problems that simple microfractures, even with AMIC, might face down the line. So this might be a little bit promising. Coming now to the golden standard technique, which is the autologous chondrocyte implantation. It is, as you most probably know, and you most probably realize now, that it's a two-stage technique. In the first part of the technique, you take a small part of the cartilage, which is sent to a special laboratory, and then when it comes back in a liquid form initially, and then back in membranes, it can be implanted in the defect area, as you can see in this slide. And what is now in the market is the matrix-induced autologous chondrocyte implantation, which is the difference between the first generation and this third generation is that the cells are already seeded and cultured on the membrane, on the collagen membrane. So the good results coming from this technique, I don't need to give you all the details regarding but you have to see in this very big study that there are some very good results, and after almost 13 years after the index operation, more than 90% of the patients would agree to do the same procedure again. So this means that they are happy. Finally, in terms of the cell therapies concept, it is down the line a good opportunity to deal with cartilage cells, chondrocytes, together mixed with MSCs. And Arno Kaplan developed this project as well, and showed that whenever they are mixed in this proportion that is presented here, the results are similar to maybe comparable to the golden standard. And this can be done in one stage, and that's the difference, inside the operating theater. When you get some parts of the cartilage, you give it in the back table to the biologist, and then during the next hour, the solution is ready to get it back, and then to inject it on the membrane, which is stabilized later with the fibrocartilage. And these are very good results coming from this approach with one-stage techniques, which are developed literally because chondrocyte implantation techniques, cultured chondrocyte, autologous, are very expensive, and we are facing regulatory issues down the line all over the world. The last and most steady, let's say, in terms of result and return to sport technique is the osteochondral transfer. We get a cylinder from a non-loading area of the joint, and we get it in the defect, creating something like a mosaic, as you can see here, which is quite technically demanding, but very good in terms of having a good result at the end. And literally, it's a very good procedure if you have the experience to execute it in the proper way, with very good results down the line, but especially for medium and not that big lesions, as you can see in the next couple of slides. So coming to the last part, we need to address all these data that we have and all these techniques in order to support our treatment algorithm. We know from several studies before 2012 that all the techniques are giving quite relatively good results in terms of return rate, but some of them are giving better results in terms of durability of the result, and faster rehabilitation, some of them compared to others. That goes into the treatment algorithm, where you can see published from Icrs in 2012 that we have 3 groups: less than 1 centimeter, 1 to 2, and more than 2 centimeters, taking into account the size, the bone involvement, and the age of the athlete. And as you can see, whenever we have an implication of the of the bone, we need to address the subchondral bone as well, either with oats or with a Macy, with a bone grafting, which is the sandwich technique. But it's also important to understand that since we know the longevity of these techniques, for a beginner, it's better to use a better technique, a long-standing technique like ACI, compared to an end of the career patient. And this was already published 8 years ago. A lot of research came down the line, but literally all the research after 2012 up until now supported all the previous described situation. And this is the one, in my opinion, a reference from now on, published a month ago in Arthroscopy, which is a meta-analysis of level 1 studies. And this says exactly the same, that all techniques are producing high quality repair tissue and have a lower failure and high return to activity rates, with the exception of microfractures down the line. And if you search a little bit deeper, you can see that there are some parameters that needs to taken into account. For example, if the patient is young, if there are traumatic lesions, and I will summarize this in after these two very good reviews, systematic reviews, that they give us very good results in terms of return to sports for all techniques. And in this one, 76 overall return to sport at same level, with better acting like osteochondral transfer and ACI, of course, not necessarily with the microfractures. And all this evidence leads to the ideal patient profile, let's say. So we need to look for a young patient who has a traumatic injury, a small defect, which can lead to better result. And definitely we need to hurry up a little bit in terms of first to establish the diagnosis and the treatment strategy. And it's a good prognostic factor not to have a previous injury or even surgery, not necessarily only for cartilage, but other surgeries play a role in this area. So we literally stay in the same line, in the same treatment algorithm, maybe with addition, let's say, of the debridement treatment during the season, which in my opinion is a good option, and not burn any bridges. You can easily access this infographic coming from a very important group of people and published in Arthroscopy. And this summarizes a little bit the algorithm that we discussed. Rehabilitation is definitely 50% or maybe 40% part of the success. And it's a topic that we need to discuss through the teams inside Aspetar, interdisciplinary. And I think that both the conference and our common conversation, and maybe establishing some protocols down the line from now on, would be a good idea for us to deal with this situation in the best way. So to finalize, I know that it was quite tiring for you, but we definitely need to have a high index of suspicion and good clinical and radiological judgment. And by this, I mean we need to trust the radiologist, but we also need to know ourselves exactly what is going on in terms of radiological appearance. There are some surgical options with good clinical outcome and return to play rates that we need to be aware of. This is definitely a multidisciplinary approach. After all, Aspetar is the holy grail of multidisciplinary approaches. So we need to stick on this, and we need to get the athlete involved. We need, of course, to respect biology, because we are dealing with high-level prima donna cells, and we need to take this into account. We don't have to think about time. We need to think about the therapy in general and good results down the line. And we need to operate and rehabilitate all our patients like being elite athletes, and not the opposite. Thank you for your attendance. Thank you for being here and to being so patient with me. And I hope that this Corona crisis will give us some advantages at the end. And when we come back, we're going to be a little bit wiser. Thank you.